Rajat can go ahead.
Ladies and gentlemen, on behalf of the Integrated Health and Wellbeing Council, I welcome all of you to another session on our Diabetes Awareness Series, which is an initiative of the IHW Council and powered by Boehringer Ingelheim. The Think Beyond Sugar campaign has been organized to commemorate World Diabetes Day and to create mass awareness on diabetes and to inspire people to move towards a preventive lifestyle and to go for early detection. Diabetes can impact you in any stage of your life. However, the impact of diabetes during pregnancy is extensive. So to discuss more about this, about the management of gestational diabetes mellitus, I am joined by a panel of distinguished guests. Let me take this opportunity to introduce them. I have with me Dr. Nighat Firdaus, Professor and ex-HOD at Department of Obstetrics and Gynecology, LD Hospital, GMC, Srinagar. Welcome to the discussion, ma'am.
Thank you. Thank you for the invite. Thank you so much.
Thank you.
I'm privileged.
It's our honor. So I also have with me Dr. Vandana, who's a consultant diabetologist at Cure Diabetes Center, Bangalore. Welcome to the discussion, ma'am.
Thank you, doctor. Thank you so much.
I'm also joined by Dr. Ram Niranjan Sahu, who's a senior medical specialist at CGHS, Hyderabad. So on behalf of the council, I welcome all of you to this very, very pertinent discussion. So as prior to the show, we were discussing about the numbers and how, this increase in numbers is impacting the whole country, in fact. So I'll just start. We will come to our, diabetes during pregnancy, but I would want to give an overview of how, what is the current status and how are things, changing. So for that, I would first come to Dr. Sahu. If we talk about the current situation, since you are closely connected with how things work in the public sector, so give us an overview of why this increase in number, what are the risk factors, what do you see as the most important factor when we discuss about diabetes?
Yes, definitely. So presently, if you think nowadays, what is happening that our non-communicable diseases, what is non-communicable diseases are mainly our diabetes and hypertension. The incidence and prevalence is increasing day by day. That is a common factor. What we have got here is our sedentary lifestyle changes and diet changes and all these pictures leading to increased number of diabetic patients. Out of that, when now today's talk is about gestational diabetes mellitus, that means diabetes mellitus in pregnant ladies. So one lady comes to us, she's pregnant. So what we want for her, we want a healthy baby and mother also should be healthy. So in that case, suppose a lady is having no diabetes and another is having diabetes, what is our role? Our role is to give her good baby. That means what is the additional problem for her? Additional problem is diabetes. This diabetes we should detect, we should control, and all the apprehensions which is there for the baby, its baby can have many complications, including mother. This should not happen. We should avoid at the end of the things, good baby and good mother. That is our motto. So in that case, if you take a lady who is likely to get diabetes, that is most important. One important thing is nowadays, as we are seeing type 2 diabetes, the incidence, or we can see de novo diabetes at the age of even 20 years. A lady coming to me with frank type 2 diabetes, it is possible. In that case, what we see that a lady could be pregnant, could have diabetes before pregnancy, and she can get diabetes, that means high blood sugar, during pregnancy. Two things are there. But impact, those who are having diabetes from beginning, they have more impact. We have to control it better. And at the same time, when she develops diabetes first time, in her pregnancy, that is gestational diabetes mellitus, we detect at the age of, we should check when you have first contact with her. First, when we see the lady, we should do blood sugar, definitely. There are rules what to do. And then definitely we do at 24 to 28 weeks of gestation. We want her blood sugar to be absolutely normal from the time we have detected. It is our duty to detect before that also. That is pre-counseling also we should do. And at the same time detect and keep it normal. Now during the course, we'll be seeing that what all complications we are going to see and how we are going to avoid this. coming to the incidence, suppose you take pregnancy, 100 pregnant ladies are there, depending on at what age she is pregnant, at what group we are seeing. Usually it is in India, I believe ma'am will tell, it is one out of five, maybe 20% or even more, we can get diabetes nowadays. And presently, as the prevalence of diabetes is even lower because of adolescence, obesity, sedentary lifestyle, and the work culture which our children have got. So what happens there that we see lady being pregnant, before that she is having diabetes. So our role is to control that properly, pre-counseling and do that.
Dr. Sahu very rightly pointed out how, counseling and of course is an important part, a question which I would have come to at the, further part of the discussion. Coming to you, Dr. Nikhat, when we talk about diabetes, in general population, and of course, because Dr. Sahu touched upon the complications, which I would, come talk about detail further down the conversation. But when we talk about diabetes in pregnancy or gestational diabetes, what are some of the risk factors, which put women at a greater risk of? Because once we understand the risk factors, we can surely make sure, especially the ones that are modifiable, if we could switch towards a preventive lifestyle.
Yes, definitely. First of all, as Dr. Sahu said, diabetes is, it is said that India will be the diabetic capital in a few years because it's rampant, it is going alarmingly high. Now, when I was a student, when I was a PG, I would occasionally see a diabetic patient. And then, we would open the books and start reading and ask our teachers and this because it was very rare. But now every second bed is occupied by a diabetic patient. So I think pre-conceptional counseling is very important. So now you'll tell me who are the patients who will counsel. Now, my goal would be that a patient should enter into pregnancy in a euglycemic state. I mean, euglycemic means she doesn't have, even if she's a diabetic, she should enter in a euglycemic. That means her diet, her lifestyle modification, even if she needs medicine, cutting down her weight. These precursors have to be. The high risk are a body weight, very high body weight, a BMI more than 30 or a BMI on the higher side, sedentary lifestyle, especially nowadays with this COVID. Now people have started working from home and sitting on the desk and the tool and not moving at all. So the weight gain has been tremendous. So all these precursors have to be addressed. So kindly, I mean, it's our duty to aware. Whenever patients come to me and they, want to conceive, I tell them you cut down your weight first. You go for regular jogging exercises. You go for a diet control. And in such patients, you would definitely like to do a blood sugar. I mean, according to the American Council, they are saying mass screening should be done. But in our setup, we may not do that. May not be possible. But if you have such, you have a you have a high BMI, you have a overweight person, you have a family history of diabetes, get their blood sugar done. Doesn't matter. It's not a very costly affair, and it can be a part of screening, right? Then, when she enters into pregnancy, one has to ascertain whether it is she was already a diabetic or now she has developed, which we call gestational diabetes mellitus in 90% of the patients. And because I don't want to go into the pathophysiology, because pregnancy is a diabetogenic state itself. Now you'll tell me why? Because so many hormones, placental hormones, estrogen, progesterone, they, interfere with the carbohydrate metabolism. They produce insulin resistance. So with the result in the early, because we divide pregnancy into three, first trimester, second, or with three parts. Earlier, you may not detect. But as the trimesters go on increasing, the insulin resistance increases, the carbohydrate metabolism gets further deranged. And they may, if you have missed it at the first, she may develop a full-fledged diabetes at 24, 28 weeks. So replanning is cut down the weight, enter the pregnancy in a very healthy state. And then once, God forbid, okay, if she develops, we should not worry. Because if diabetes is controlled in pregnancy, it's like a normal pregnancy then. If it's uncontrolled, it can create havoc on the mother, it can create havoc on the fetus. Now, if you start the problems with the mother, diabetes, it can lead her to hypertension, it can lead to nephropathy, it can lead to retinopathy, it can involve all organs because it's going to affect the vascular system, right? But as far as the fetus is concerned, the baby growing inside the mother, they can be right starting from the first month of pregnancy. She can have problems. She can land up in abortion, she can land up in preterm labor, she can get a very big size baby, which has again difficult deliveries and traumatic deliveries. Then she can even get a smaller baby. I mean, like there's a myth that diabetic patients get big babies, but if the diabetes is affecting the vascular system, the blood supply to the baby will not be that good, and you will get an intrauterine growth retarded baby. And then once the baby is born, the baby has so many problems: hyperglycemia, hypoglycemia, hypothermia, because the body surface area is different. The respiratory system develops very late in these babies because of the insulin and carbohydrate deranged metabolism. So we need to address it and we need to control it. Uh, Prevention, I told you, but we need to address it. We have to aware the patient that they should not be initially, if it's a borderline, diet, exercise, lifestyle will help. But later, they should not be scared of taking insulin. This is one point which I want to, stress. Because the moment we tell the patient insulin, she gets really jittery. अब पेट में इंजेक्शन लगाना है, इसमें लगाना है, subcutaneous लगाना है. Nothing to worry, because it is the safest thing. It doesn't cross the placenta. Placenta is a connection between the mother and the fetus. So through the placenta, the baby gets everything, but will not get this insulin, right? So this is safe. It doesn't cross the placental barrier. When it doesn't cross, so it is safe. So mother will be her blood sugars will be controlled. Once her blood sugars will be controlled, baby will be fine. There'll be nothing wrong with the baby, right? Then second thing which I want to request everybody, that when the patient is put on insulin, we know we are all not very literate and not very educated. It's the duty of the doctor to tell the mother that when she's on insulin, she should, once she's taking insulin, keep the food by her side. Like she'll take insulin, then she'll go to the kitchen, start preparing her food, cooking or frying or whatever. It takes 10, 20, 30 minutes. And by the time her blood sugar goes down. And the blood sugar going down is not a very good thing. It can suddenly cause of intrauterine fetal death. So as a doctor, when patients come to me, I tell them, if you are taking insulin, who prepares food for you? Or have you kept your food plate by your side? It's not that you are taking insulin from one arm and another 1 minute to take, but it should not get prolonged, right? That is another. Then, as far as if you want to pregnancy, antenatal care in diabetes is exactly the same as it is in normal, but there has to be some, something little different, because blood sugars are already deranged. You are putting them on medicine. So we need certain scans, like we call them dual marker, triple marker, NT-NB scan. And at 24 to 28 weeks, we need a fetal echo, because diabetes, many of the times, leads to certain congenital malformation, especially affecting the heart. So at a fetal echo at 24 weeks, because how it makes us wiser. If we detect something, we know we have even surgeries inside the womb these days. The medicine is so advanced that we can do in certain intrauterine manipulation. So why to miss that chance? Or even if we detect something, we at the time of delivery, we are ready that the baby may have this problem, we can deal it immediately. Certain problems are to be dealt immediately once the baby is delivered. So with modern technology, we have all that. Then once the patient delivers, kindly don't forget that, don't leave the patient like that. It is seen that the patients who have gestational diabetes have to be followed for 10 to 15 years, because they can turn out to be diabetics later in life. So it's not that she has delivered and we have a baby and we have a mother and everything is gone and blood sugars have come down. She needs to be followed up and she needs to be educated regarding her diet and weight, even postpartum.
Right. That
even
is very
postpartum. That
Yes.
postpartum वो बिल्कुल free हो जाएगी. Now nothing is,
That is
baby is normal, everything is normal. Let me go on eating like a glutton or something like that and leave a sedentary,
yeah,
not
that is
getting up at all.
yeah,
That's not to be done, because follow-up is very important.
very
Kindly don't forget that patient after delivery. You
right,
just follow up, and she has to be a patient with you,
right.
I mean, throughout the life.
Right. On follow-ups, I will come back to you, Dr. Nekat. Dr. Vandana,
And one more thing regarding the mode of delivery. Cesarean is not a rule. It's a hard and fast rule. Diabetic mothers can deliver normally. It's not that cesarean has to be done for diabetes. It can be done for any other indication, obstetric indication.
Yes, so you have addressed many myths that people have regarding diabetes and pregnancy, about how, they can take those medicines and which will not be impacting the child.
Not at all.
Yeah, so that was a very enlightening, discussion. Coming to you, Dr. Vandana, when we talk about, diabetes, and since ma'am and sir has already covered and given us so much background on how India is, the numbers are increasing. So when we talk about diabetes and a preventive lifestyle, especially, you think we Indians as a race, people say, are more prone maybe, but what about our social, way of living? I mean, how every happy occasion has to be followed by some meeta, and then of course we have very heavy diets. So just enlighten us on that aspect.
Okay, so coming to this, our social status, what we stay in, and as you said, it is you rightly mentioned. And post-August, it is all the festival season, which just comes back to back. So the last 3 months, it has been the same way. People till August who were like very strict in control, it is like Ganesh Chaturthi comes, then there is Dashara, and then there is Diwali. They're like, madam, till then we were under good control. So why not have it one day? And sweets are such a thing that once you start, it is like unstoppable, just like Lays, no one can eat just one, and the festivals are coming back to back. So they just start and they're trying to cut down, another festival is there. And another thing is, in India, even though I stay in Bangalore, a metropolitan city, I still feel people have that stigma that wherein I just go out and openly say I have diabetes, so I cannot eat sweets, people still don't take. Even the most educated people will not take it. So I have a couple of my patients who work in MNCs and multiple sectors at like a higher position, where they can be an influential person to help people around them about the health and society in their working community. They can tell, but still they're scared to tell that that I have diabetes, so I will not be taking sweets. I mean, they still have that kind of hindrance still that is there. This I can just quote an example. I just had a bank manager like a couple of weeks back, and this was during the Diwali festival. His sugars were raised, and I asked him, and he was like, no, we had Diwali celebration in the bank and we had this feast. And so I just asked him, sir, like, you are in a senior position and you will have so many employees around you. So you can set an example to them in your health. Like, you can tell, see, this is what is my health status. I have diabetes, hypertension, or so and so. So I will just cut down on this much amount of sweets, not more, so I can continue with a healthy diet. Is like, no, I cannot say that. That cannot be happening. I cannot tell my subordinates that I have diabetes. So the way they look at me as a boss will change. So that thing has to be definitely changed. So that is one aspect. Another aspect I tell is, no matter how much we say we are forward, we are advanced, men and women are given equal chances. As a society, when we come back to the home, the importance of women gets in the house compared to the male population with respect to diet and exercise is still not kind of met. That I still feel that is an unmet need. So woman is there, she's working, and her husband is there, he's also working, he has diabetes. The way the lunch is prepared and packed and his schedule is done in such a way that everything is done, ultimately she is so tired packing the box for everybody and cooking and all that, she ultimately carries a box of rice or something just for herself. The diet is still not met. So here I wouldn't blame the society. Even the women have to take responsibility for themselves. When they can take that extra time and step and go ahead and do for the male population or their spouses or counterparts, why not take that extra 5 minutes for themselves? When you can pack like a total plate for a husband, do the same thing for yourself. Why will you put yourself down? So these two aspects has to be met, and I feel as healthcare professionals, maybe we cannot change it overnight and in one day. Throughout our counseling, when they keep meeting us, reiterating the importance that even a woman is important in the family. So take care of yourself and your health too. Maybe over the time, the counseling might help them and change.
Right, Dr. Vanna, very rightly you have pointed out about that equity, gender equity has to be, even when Dr. Nigat was talking about how a woman has to first take that, insulin and then go for dinner preparation. Dr. Sahu, you would want to add something, so because we are all, having one perspective. What about some perspective from your side?
I would say same thing like Dr. Vandana told, that people are not accepting that they are having diabetes. Once you accept diabetes, then only you will think that how to control it, how to manage it, and how to prevent complications. Just I'm a little beyond diabetes, pregnancy I'm talking, like a highly placed person, he doesn't accept himself as a diabetes. Now you consider that person is taking insulin. Some people are 2 times insulin, some people are on basal bolus insulin 4 times. So he has to take insulin morning, afternoon, also lunchtime, night also. When he's in office, or even children you take, like type 1 diabetes, they are having they have to take insulin on basal bolus 4 times. So school, how to give insulin. So we have to educate all of them, make them aware that insulin is needed. It is not, it is thought that as if you have taken insulin, it is the last stage of diabetes. That is the concept we have got. That has to change. When required, we are giving insulin. We are giving tablet for adults, I'm talking type 2. We are giving medication. Beyond that, when it's required, we are giving insulin. In children, we are giving, of course, type 1, we are giving insulin only. So we have to make aware in the school, every aspect of life they should know. And to take insulin, there should be, maybe if it is required, some privacy or something, first thing they should accept. If they accept, they can change the thing. So that is more important. That is also same for pregnant ladies. Suppose we start them on again, we can give again basal bolus, or every 3 meal we can do. Sometimes we give regular insulin 3 times. Then also they should accept this. They should not think that once I've taken insulin during pregnancy, of course, they may develop type 2 diabetes later, but to make herself, her sugar all right, her baby should be all right, she should accept insulin and take without any hesitation. That we are to teach them, we have to tell them. We may require 1 time or 2 time or 3 time insulin, that doesn't matter. Our aim is to make her sugar absolutely normal. And in pregnancy, we need very tight control of blood sugar in order to avoid all the complications for herself and the baby. So the control which you want in a non-pregnant lady or an adult male or female, that is, we can to some extent relax. But as such, the control in diabetes, diabetic mother, diabetes control should be absolutely normal, I would say.
Right, Dr. Sahu, very rightly have pointed out. Coming to you, Dr. Nigat, since you talked about how, and even Dr. Sahu also discussed about how, during pregnancy, it becomes all the more important for women to, keep a check on their blood sugar levels. So are there some additional, screening methods or tests that women have to go, or is it just a routine checkup that they go for during pregnancy, and that would be enough to, detect any problem if there is?
No, actually, as I told you, if there is a history of, if there's an obese patient or history of family history of diabetes, previous big babies, then first time when she enters your clinic, you have to go to get her blood sugar done. Second would be at 24 to 28 weeks. Then I told you additional screening is to be done, because even if you control the diabetes, maybe sometimes it fluctuates. And then that very time it may affect the fetus. So you need certain additional, for all patients, you don't need dual marker, triple marker. Those are certain tests, which I will not go into detail, or an NT-NB scan, or level 2 ultrasound. So in these, you have to be, it has to be more, closely done. That is one. Then the growth of the baby has to be seen. And as a doctor, it's my duty to tell the patient the signs of hypoglycemia and hyperglycemia. So when patient comes to my clinic, you have to keep her aware that if she's on insulin or she's on diet, suppose her blood sugar falls drastically. So falling of blood sugar not only will cause a death in the baby IUD, it can cause it can, throw the mother into arrhythmia, it can throw her into convulsions. So she has to be told that if any time you feel, fatigued or jittery or, lethargic, you just put a bolus of, pinch of sugar in your mouth. So she should carry. One is that these patients should carry the card along, and then she should carry some sugar candies with her. So you never know. Maybe she has taken insulin and then she did not get time to take food. So she should hypoglycemia. And hyperglycemia is also a worse thing. Hyperglycemia can lead to ketoacidosis, and then the patient needs to be, so she has to be told about those symptoms. So when patient comes, spend 5 minutes with her. 3 minutes. Tell her that if you get any of these things, immediately rush to the hospital. Or if you find signs of hypoglycemia, just put a sugar candy in your mouth. You will definitely improve. I have practically, seen one of my patients, not pregnant. She, by mistake, she had to take some. She had to take this antacid sort of a medicine, and by some doctor have not written legibly, so the market person, the chemist, gave her anti-diabetic drug. She happened to be our neighbor. And then when she took that, she started deteriorating. Her sugar started falling. And I don't know what it is. We have all have faith in these dargahs and other things. And she had got some, candies or shirini from one of the mosque, or I don't exactly remember. But when she was, her blood sugars were going down, she was sweating. She said, "Oh my God, save me, let me take these candies this time." And her blood sugar shoot up and she started improving. So these things have to be kept in mind. And hyperglycemia can be very, very, it can lead to ketoacidosis, it can involve the kidneys. So you have to tell them that you may sometime get palpitation. So the antenatal care has to be little, you have to spend little more time with these patients. That is the crux of this, that it's not to be taken as a normal. If it is controlled, it will turn out to be a normal pregnant. It'll behave like a normal. But for us, regarding this insulin, regarding food, regarding the signs of hyper and hypoglycemia, have to be told to the patient.
Right, Dr. Nigat, that is very important. It is only through early, when you have awareness about early symptoms and signs, then only you would be able to seek medical attention for that matter. Coming to you, Dr. Vanda, when we talk about, how important is your weight management, we have talked about how some modifiable risk factors are there, but when we talk about, especially with the focus on pregnant women, so what is, if we have to tell our general population, especially women who are our viewers, how to make sure that even during those 9 months they how can they, some tips and strategies like doing small walk inside the house only, some important tips that they can use proactively to manage their health.
Okay, so again, here it depends on a couple of factors. So any women who just enters pregnancy, so we'll have to look into two things. One is the lady entering pregnancy who was diabetic earlier, or the lady who is developing diabetes once she enters pregnancy. So these are the things. So for a lady who is already diabetic and then she is entering pregnancy, and as already ma'am said, so she has to enter euglycemia and then enter the pregnancy. So she would be knowing the importance of exercise. So here, she knows how important it is, the exercise, to get down the sugars. So there, spending a little less time would be fine. So, but a lady who enters pregnancy normally and then develop diabetes, the task comes there. Because usually in India, how our population and the pregnancy is treated is like, it is like a sweet 9 months, and the lady is completely fed, like she has to eat whatever she wants. And the diet in pregnancy is eat whatever you want. That is all is the main factor. They don't even look into the medical comorbidities, be it hypertension, diabetes, or anything. So there, what happens? Taking small frequent meals, like as we said, the age-old practice we are doing, that definitely helps than 3 big meals. And so that is usually there. So again, it is like pregnancy, what I have seen, in my practice, it is like people, they eat throughout the day. throughout the day, it is like non-stop munching, like school kids, how the kids go to like play home, come back and eat. That thing is following. That thing definitely has to be stopped. And retrospectively, when we go back and ask them, why are you even munching like this throughout the day? This will definitely not help your diabetes. And the answer we get back is, no, my doctor told to eat small meals frequently. So so when we say the small meal frequently, we definitely have to be particular. Like what time you have to eat and what is the small meal and how many times, that definitely has to be told and explained in particular, because most of the doctors, because the OPDs are busy, when we look at a patient, it's like small regular meals, they'll feel the patient is educated, she will understand, and that will happen. Like take small frequent meals at regular intervals and things will be fine. And this lady starts munching 24 hours. So that should not be the thing. So when we say small frequent meals, the major meals, 9-1-9. So breakfast, lunch, and dinner. So divide that whatever you're eating into 2 halves. So 9 o'clock, 11 o'clock, 1 o'clock, 4 o'clock, 9 o'clock. So divide it in this way. This will definitely help the sugars to be reduced. So if we have to, because there will be people who are attending this, I mean, in general terms, if I'll have to say, if we take dosa into example, random lady eats 3 dosas for breakfast. So what I would say, take 1.5 at 8:39, another 1.5 at 11. So this is what we called as small frequent meals. So whatever you're eating, cut that down into equal halves and take it at 2 hours intervals. So another thing, what happens is, coming to fruits, when we talk about fruits, it is not that all diabetic women should be avoided fruits based on the sugar levels, whatever there are there. If they're like a little higher on the range, but still fruits can be taken. Make sure you tell them you have your breakfast, whatever you are having, the half amount at 8:30. At 11 o'clock, instead of having this other half of breakfast, keep a fruit bowl at that time. So you eat your main meal, followed by fruits will definitely not happen, because one meal you eat, there'll be spike of sugar. You followed that by a fruit, again the spike will increase. So give that 1.5 hours the gap and take a fruit bowl. So definitely the spike would have kind of come down with your insulin or medications, whatever you are, and that will help. And this is what it is. And another thing, fruit balls, another thing is dry fruits. I would definitely like to mention pregnancy. I mean, you'll have to eat more, start eating. It is like people absolutely have no count on that. They just keep bowls of it, or they just have it randomly in their hand, walking left and right. They would have taken dry fruits. I'm not saying it is not right taking, but it depends on the sugar values, whatever you have. So you usually in actual diabetic lady entering pregnancy, I would say a handful of nuts, again 8 to 10 nuts per day. If it is mixed nuts, take 8 to 10. All the nuts together, 8 to 10. Because this I'm reiterating on the number, because handful is again different. My handful is different, and your handful is different, and another random lady's handful is different. Because all these are the practical aspects. When we read and write exams, it is different. I write handful of nuts or small frequent meals, it is there. Practically, when we come, every individual's thought process is different. What I think might be different from what ma'am thinks. What ma'am thinks might be different from what sir thinks. So it is different. Please give the numbers, is what I request everybody. When I say handful of nuts, 8 to 10 nuts per day. So that can be taken. Another thing is coming to walking, as you said. So after each meal, 10 minutes of walking after each meal is definitely what is advised, which I think only a couple of people will be able to follow, and most of them will not be able to follow. Otherwise, 20 minutes of leisure walking morning and evening should definitely help. And again, other forms of exercises, again there are people who will do little vigorous exercises. This again should be dependent on the type of pregnancy. Somebody who's hypertensive, I cannot tell do vigorous exercises or resistance or anything, that kind of exercises. And here again, I would say, if at all, if the obstetrician has told complete bed rest, no exercises, definitely, no matter what the sugar levels are, exercises are totally avoided in such kind of pregnancy. Special cases which requires total bed rest, in such scenarios, no matter what the diabetic status, we would advise them to follow the rest told by the obstetricians, because that will play a major role as compared to the sugar levels which we can reduce with respect to diabetes.
Here I would tell,
yes,
Dr. Vandana, I would like to tell, there are only a few conditions where we advise rest.
Exactly.
Otherwise, rest is deleterious in pregnancy because pregnancy is already a hypercoagulable state. So when you ask the patient to rest, what will happen to the blood circulation? Then what will happen at the time of delivery? So when I get patients, I tell them their attendants come and other their mothers and the साथ वाला जो होते हैं, they say इसको rest लिख दो जी. I said no, it is detrimental to her because there will be no circulation. There can be clot formation, there can be embolus, there can be except a few like placenta previa obstetric condition where we know she needs rest. Otherwise, I again say it's a myth to have rest. Yes, in hypertension, in severe, we say that rest increases the renal blood flow and resting in the left lateral position, that helps. But a diabetic patient taking rest and sitting together, it will add to the fuel to the fire. You know, uh, if as for a layman, I I think for diabetes, three whites like the white bread, maida, whatever it is, sugar, rice. These have to be, if not totally cut down, these have to be out of the her menu. And then in fruits also you have to, grapes. They will usually ask you, can I take grapes? I don't know which they usually ask. Then we tell them take lots of dates because it's full of iron. But for diabetic patient, it's not like that. So that's why I was focusing that we have to spend a little more time with the diabetic patient to explain to her, because on the one side we are telling them take dates is full of iron, आपका iron बढ़ जाएगा, खून बढ़ जाएगा. So for a layman, she doesn't know, she'll go on taking and her blood sugar will spike. So the food has to be, there has to be some. And we say that the pregnancy weight should be overall 10 to 12 kgs of her basic weight. But a patient who's a pre-diabetic is already 80 kgs. We will not advocate a 12 kg gain. She'll become at the time of delivery 100 kgs. So there, this weight gain changes. She can go up to 8 kgs only. But then definitely that will affect the baby's growth. So the food and the diet and the exercise are very important. There's nothing like bed rest.
Just I can add one point.
Right. Yes, Dr. Sahal, please.
What I want to say, ma'am and Dr. Vandana has told very clearly, they have told how we have to manage that. The most important thing is that, as ma'am told, weight gain. So we have to see the pre-pregnancy weight. If overweight is there, 7 to 10 kilos. If underweight, another 2 kilos extra, 12. Up to that we may allow. So this we have, when we are allowing this, the stage-wise, this weight is increasing from first trimester to third trimester. So each trimester will have a different diet plan. So according to that weight, how many calories we have to give to our pregnant lady, we have to decide, and we have to plan out this is the diet for her during one trimester, like first trimester. Second, it will change. Third, it will change. It will happen like that. During this process, what you have to do, this diet, as Dr. Vandana told, we have to divide it into different portions and give. So why we are doing all these things is, most importantly, ma'am told that we don't want hypoglycemia, we don't want hyperglycemia. And as we know, in diabetes, we want fasting less than 95 and 2 hour postprandial 120. It is very, very difficult. I can tell you, to achieve this, it is a really difficult process if the lady is diabetes. And we are talking of pregnancy diabetes, definitely. So once we are doing that, so we have to emphasize our lady that you have to do frequent blood check. And that home glucometer, they have to do many number of times. As many number of times depends on the diet what she is taking and what type of insulin she is taking. So according to that, we have to do the checks. Most often what we see, they're reluctant to do the blood test. So once they don't do the blood test, we will not know that what ma'am Vandana has told, that if you take this food, how much sugar is increasing. So each time when they are giving food during first trimester, second trimester, third trimester, diet will change as the calorie requirement is increasing. And when we are giving different portions, 5 portions we are given, which portion we are given maximum, that time we should see after 2 hours what is postprandial blood sugar. If that is going up, reduce the diet. And you see that most of the time your sugar should be, ideally we want 120, maybe 120, 130 also we can allow all this. So that we will see that remains in that level. And once she gets used to that, in one particular trimester, this portion of diet, so many number of times, hopefully her sugar will remain normal, and then she can do little less number of sugar check. Otherwise, sugar check we have to do more frequently, and they're very reluctant to do this. That is more important. And
Self-monitoring is very SBM we call it, self blood testing monitoring is very important.
Yes, yes.
Especially, I tell you what happens, these patients take late night. Suppose a particular patient has been told to take insulin in the late night. Sometimes what happens, she has taken food little less, and then she has taken full insulin. And that is known as the Samogi or the effect. And in the morning at about 4 o'clock, the blood sugar goes down to
Down.
60, 70, and suddenly they get an IUD. So she has to use her brain that time. Even the family members should be, well versed with it. If she has taken a little less food, and she may decrease the dose of insulin that time. She may take 1 or 2 units less, because in the midnight she is fast asleep. She doesn't know what's happening. Suddenly she gets up and she finds loss of fetal movements. So that is to be self-monitoring is one of the very important things to be people to be made aware of self-monitoring of blood sugar.
And once we are doing this, I would just suggest that various glucometers are available. Whatever glucometer she is using is quite good enough, but she should check sometime with the lab also. Same glucometer should be calibrated with the lab, so that we believe more of the lab report. And lab we cannot do all the time, as ma'am told, nighttime we cannot do. So once it is standardized glucometer is there, nighttime hypoglycemia is most dangerous. We don't want that. So she has to...
Of caregivers, that is very important, because when we talk about women in India, it's the husband or the family members who are the final decision makers. So when we talk about your in your clinical practice, do you also counsel the partner about the various aspects, and how important is just including the caregiver in the whole journey when it comes to
yes, definitely definitely the people around the house should know, because if the suppose the patient gets a severe hypoglycemic, what happens, they start feeling palpitation, they start feeling sweating. By the time, if the husband is also well versed, something is happening, he can immediately help her out, because we have seen sometimes they almost get a syncopal attack, so she doesn't know what to do. So if the husband is made aware that you have to keep track of these things, or the husband cannot be all the time around, or the people in the house, so they can be helpful to her. They can be helpful to her.
Very rightly, we have talked about the importance of counseling when it comes to caregivers also. Dr. Vandana, coming to you, because we have been talking about self-monitoring, so you think this technological, advent, and how there is with a smartphone even you can monitor, your vital stats as such. So do you think this whole technological innovations have somewhat changed the scenario for the better? What is your take on that?
Definitely. Technology has played like a very important role now. As Sir said and Ma'am said, SMBG people are very reluctant. So maybe the initial days, they are very apprehensive. Maybe the first 1 or 2 weeks they would do, and slowly the SMBG values will start coming down. Initially, they might come to me with like 10 to 12 readings. It might come down to 8, 4, and 2 at sometimes. So your technology really has made a change. So talking about CGMS, the continuous glucose monitoring system, which just comes as a coin patch which can be applied, and 14 days sugars can be monitored out of it. Yeah. So this is like a boon for people with pregnancy, or even without pregnancy for diabetics. This is like a boon. So most of the people have taken it well as well. So as Sir said, like each time we have some food and you monitor, your sugars are raised, and next time you cut down on the food. So CGMS will definitely do the job there. So ask the people the lady or the family member to track the sugar values for the next 15 days. So you will actually have, like, whatever we eat throughout the pregnancy, a 15 days count will definitely give us a picture what exactly it is. So note down all the food, whatever you're eating, and track it just by scanning the device with the smartphone or the sensor. You will get the sugar values. So that way the lady is aware like what she has taken and how much the spike in the blood sugar is. So next time she's aware that she's supposed to cut down on that food, or maybe the quantity or even the item itself she has to change, or as we say, combine carbohydrates with with fats and proteins, she can try that method as well. So for that, in that way, continuous glucose monitor system has definitely helped. And another thing it has helped is, as ma'am said, the midnight hypoglycemia, whatever people expect. So say, for example, the lady has taken insulin and food by 9 o'clock and 10 o'clock, she goes to sleep, but somehow she's not able to sleep. And 12 o'clock, she's not sleeping, just get up, take a scanner and check the sugar values. And if at all, if she sees that falling graph from 10 o'clock to 12 o'clock, that itself will give her indication that she might go into hypo later at 3 a.m. or 4 a.m. So that at 12 o'clock, she can just munch on something or a glass of milk, which will reduce this hypoglycemia at 4 o'clock. So with this smart system, definitely. Now, just because she's not fallen asleep, there is a sensor with no pricks we can check her sugar value, she'll be happy to do that. But that only if I ask her to prick at 12 o'clock because you're not sleeping, check her sugar level, nobody will be happy to take that point. Just because I'm not sleeping, it's not that I should get up and check my sugar values. But because there is a sensor, she has a smartphone handy, why not check once? So in that way, technology has definitely done wonders with respect to CGM. And another thing I would like to add here is, now that we have many applications which will share the sugar values at the remote levels to the doctors and even the caretakers, be the
Exactly.
husband or family member. So the lady is on CGM. And she is quite, I mean, not everybody, a few cases we might see people will not experience that hypo symptoms. But this alarming beep or indication will go to the doctor or the family member. So through that, they can inform them remotely that you're going into hypo, start eating something, correct the blood sugar values or alter the insulin dosages. So that can be done. So this way, technology has definitely helped people.
Yes, definitely helped.
Right. Dr. Sahu, you would want to add something to?
Yes, definitely. That will work. Dr. Vandana has told very nicely. We should do that. Of course, everything comes with a cost. As you say, cost will be a little more. Of course, that we'll do. And most importantly, again, we do this, but pregnancy again is 9-month duration. And once we know 15 days, we can correct it. But whatever we at the end of the story is, our pregnant lady should follow clearly. And the same principle we can do for 15 days, then we can correct it. Again, we have to check this another 15 days. So comes with little cost. Definitely it helps, but each technology, she has to utilize it and convert it into practice. That control, if she does, that will go well. Of course, technology helps very well. And she would not have to prick so many times. Already we had put the in her body. It will come nicely. Sugar report will come in graph. We can show to doctor easily. But the advice should be followed. If she doesn't take the advice, then by putting the technology, we won't get that much benefit, of course.
Right.
Definitely, that will help. Definitely. And we have beeps also, like when low sugar is coming, beep will come. That is also possible. We can do that, definitely.
Dr. Nikhat, coming to you, something that you spoke about in the start of the discussion, that how, postpartum follow-up is also very important. So give us some insight on that.
Postpartum is very important. Postpartum for the mother, and postpartum, the baby has to be looked after. Suppose we say that the mother is diabetic, whether poor control or good control. Let us presume she was diabetic and she delivered. Diabetes is pregnancy. So the baby has to be immediately fed. You know what happens when they get a cesarean? They say, नहीं ये इसको what you call in Hindi, इसको मुश्क लगा है तो ये दूध नहीं पिलाएंगे. So that's not to be done. The baby, because these babies have tendency of hypoglycemia, because the mother has been on insulin on a long time, so the baby has tendency to hypoglycemia.
That is one. Also a myth, Dr. Nikhat, if I may interrupt, because many people say that since the lady was diabetic, so breastfeeding should not be initiated.
Yes. Then if it is a cesarean, then all the more they say, nee ji, ab isko anesthesia lag gaya, we will not give her milk. Then they also say that no, she cannot feed because she is operated, or even with normal delivery, at least they cooperate. But immediate feeding of the baby is very important, because what happens if you don't feed them immediately, then baby gets hypoglycemia, starts convulsion, and baby needs a NICU admission. And then they start with tachypnea of the newborn. So postpartum, don't think baby ho gaya to bas hamara problem solve ho gaya. That is not to be done. And the babies, usually these babies, if not properly controlled diabetes, they are macrosomic, means their body surface area is very big. So they lose a lot of heat from that surface. So they get hypothermic. जो ठंडा हो जाता है बच्चा. So that is to be so they have so many hyponatremia, hypothermia, uh, all these, they are liable to all this. So immediately the baby care is very important. As far as the mother is concerned, right? Of course, you can within 1 or 2 readings you say that insulin, the sugar has come normal. You may stop insulin, but you don't stop the follow up. You don't stop the follow up. You have to follow this mother, and she has to be purpurium. She has to be followed. She has more chances of infection. She has more chance of failing lactation. She has more chances of bleeding after delivery in the postpartum, which you call lochia. So she has to be continuously monitored. Beyond that, she has to come to her doctor initially, maybe 3 monthly, 6 monthly, then 1 yearly, then after year she has to do her blood sugar, because it has been said that in later life. And then another thing has to be, now a lady of 32 years delivering, she will deliver in another 2 years or 3 years. So she needs to be on a follow-up, because she has to enter another pregnancy. Then as far as contraception, of course, because diabetes affects the vascular system also. So we would like to give them some spacing. Some spacing has to be there. She should not conceive very immediately. It's not that, because we want to go her into complete euglycemic state, and then of course she can continue. So you can give them some sort of contraception. Then regarding the food, a patient who's diabetic, once she is out of insulin is or baby is delivered, she thinks she can eat any damn thing. And the garwale bhi bolenge, but she is delivered, give her this, give her that. That's not to be done. The body weight has to be still maintained, because it will no time it will take to come up again, and then she may further develop these abnormal blood sugars. And the problem is that time she'll not be monitoring, because she thinks now it was during pregnancy, it's gone, and 2 or 3 tests were normal, nothing. She will not know when she turns again a diabetic. So the food has to be taken care of, postpartum also, the exercise has to be taken care of, the baby has to be taken care, and breastfeeding has to be educated. Breastfeeding is definitely to be educated.
Dr. Nikat, coming to you, Dr. Vanna, since we are already, we just have 7-8 more minutes to go. I would just want to know, since we are talking about that level of, because when we talked about every discussion led us to awareness and counseling, because, until and unless you are aware of the problem, you are not going to seek a solution to that. So when we come to awareness, you think these, like the way we are discussing right now, what important role is that social media platforms, can play in this awareness? And do you think there is a downside also? Because, there are body image issues, and then you see influencers and people, after people are like, if you look at somebody like Alia Bhatt, oh, she has lost so much of weight, and, postpartum, and she's looking so fit. So there's this kind of image that women want to be, and so there is a lot of information. So how do you safety net that information? How do you provide a kind of hold on that?
Exactly. So again, providing a hold is like, we don't have a safety lock on Google or Instagram or Facebook anywhere we see. It is like people are just open to all kinds of information. So here, as a healthcare professionals, it becomes important for us to tell people what to follow and what not to follow. So that becomes, whatever source of information they're getting, tell them to cross-check, is it reliable? Based by scientific, I mean, is it backed up by a scientific data, or is it backed up by some kind of safety data which they can follow up on that? So it is like, I wouldn't say all influencers are wrong or all influencers are right. There are quite a few people who would follow that proper scientific methods, and each and every time they post something, they have a data which is written, which is followed up or backed up by some research journals and all that. That is fine. And something which is not backed up by that, just randomly put up on social media, definitely that has to be cut down. Like, as you said, like Alia Bhatt delivered and post-delivery this is what it is. I would like to tell people at such to come into reality. See, for celebrities or somebody who is definitely in front of camera in public images, their whole work is to be in front of camera, in front of the public. So there is no other thing which they'll have to concentrate. The minute the delivery is done, the baby is delivered, they'll have to be back to their profession, because that is their profession, that is where they stay. So for that, the image becomes definitely important. And I wouldn't say they would have done something wrong or something drastic. They would have followed the methods for that required 24 hours in a day, 4 months together. They would have given their time just to get back to their normalcy, whatever they were there. But in a normal Indian population, a normal Indian woman, giving that 24 hours completely for weeks together for her to get back to normalcy is definitely not possible. So she will have her own commitments, family, career, work, everything that has to be given some kind of importance. So that has to be told, and social media definitely plays an important role, as I said, because these days people are looking more into social media than into doctors, professional hospitals, or anything like that. So these kind of things, especially the population between 30 to 35, will definitely follow such information given by on the medias and platforms like this. And more of such things, definitely people will follow, maybe not overnight, over days or weeks or months. Definitely this will sit in their minds and it will follow for generations later.
Right, Dr. Vanna, that indeed was a very, very rightly put point. And I'm afraid we are already running short on time, but that indeed was a very, very insightful discussion. And I'm sure that the audience took away, especially women, took away a lot of relevant information, and how it's important for women individual with diabetes who are going for pregnancy, thinking of conceiving, to have a proactive discussion with their healthcare providers and to better manage and prioritize their health over other non-important matters. And I'm sure our audience will be very happy with today's discussion. And thanks to all our experts for taking out time from their busy schedule. Dr. Nighat, Dr. Sahu, Dr. Vanna, thanks for being with us.
Thank you so much. Thank you so much.
It was a delight having you all. And that is all for today. We'll see all of you again tomorrow at the same time for another important discussion. Till then, have a nice weekend and keep following our social media pages for more updated information on health. Thank you.
Thank you. Bye-bye.